Hi, I'm Steve Walling, lead sonographer at a major teaching institution, and I look forward to spending the next few moments with you discussing techniques that will be helpful in achieving quality imaging with Luminity. When imaging with Luminity, optimization is simple. It's important to note, though, that each patient is different, and with certain pathologies, different techniques can be used to help get an accurate diagnosis. Before we jump into optimization techniques, remember, Luminity is another tool that we have that improves cardiac diagnosis, similar to how we can't quantify aortic stenosis without spectral Doppler. It's important to follow the established guidelines for contrast. Some of these examples are chamber dimensions and volumes. As we know, our volumes are much closer to those of MRI, which is the gold standard, with using an image-enhancing agent. Also to document and exclude certain LV structural abnormalities, especially in the apex. For example, non-compaction, apical hypertrophy, and apical aneurysms. Here we have an example of a young woman, 35-year-old, came into the echo lab with history of hypertension. She also heard a murmur. Now, as a sonographer, that first look at the indication really is the first step, is the first process where you start thinking of why we're actually doing the echo. And that's what makes being a sonographer so unique. You know what the doctor is thinking. They only see what we image, so it's important to know why you're actually doing the echo. There's always a specific question that you have to answer, and going further to that, as we discussed today, when using Luminity, if there is a specific question, you want to take that back and, okay, well, what can I do with the administration or actually with the knobology on the system that can help bring out that specific pathology or answer that specific question? So here, my question is, the function looks okay. The left ventricle looks a little thick. We can see some of these heavy trabeculations. Now, this is a lady with a history of hypertension, right? Look at that inferior septum. It looks pretty thick at first glance. Can't really see the apex. But if I were to ask myself why we're doing Luminity on this patient before I'm about to inject, I want to know if this is non-compaction, right? Her function is probably fine. It looks okay. I can't really see the apex, so I definitely want to opacify the apex, as most of our LV structural abnormalities are associated with the apex. So I went ahead and used Luminity, and we look at the image on the right, and we can see it almost looks like a completely different echo, right? Not only do the trabeculations wash out, so this lady doesn't have non-compaction, but we kind of look at that inferior septum. Look how truly thin that myocardium is, right? In hindsight now, we can look at the septum and we can maybe see where that true endocardial border is. But without the use of Luminity, it's very hard to see that on this patient specifically. And this is a patient with decent image quality, but like we mentioned, someone who has pathology. I also like to look at this as an example for volumes. As I mentioned, our volumes with the use of Luminity are much closer to those of cardiac MRI, which is the gold standard. And so if we look at the unenhanced image on the left-hand side, and we had 100 people in a row measure a diastole and a systole, there'd be a lot of discrepancies, and I would almost guarantee that we would underestimate the volumes. We look at the image on the right-hand side, you can clearly see the endocardial border, right? And we could be much more consistent on these patients, which really plays a huge role, especially in those oncology patients that we see growing and growing in the echo lab. This is an example of just how much we do underestimate the volumes in patients. This image is showing a patient apical two-chamber view where we got an end diastolic volume of 64. If you just look at the image side by side, it looks like it gets thick there in like the mid to distal anterior wall, and that's what we might count as our volume. But then when you use Luminity, you can clearly see that true anterior wall. If you just look at the volume on its own side by side, we definitely completely underestimated on the left and actually almost doubled the volume from 64 mLs to 120 mLs in this patient. So let's now discuss Luminity optimization techniques. Before we discuss the simple techniques to optimize your Luminity images, it's important to understand that not all ultrasound enhancing agents are alike. Luminity has unique characteristics that contribute to the consistency, image persistency, and performance that we achieve with Luminity. The composition of the Luminity microbubble is unique. It's composed of an octafluoropropane gas with a phospholipid shell. Now, these phospholipids are an important component as this significantly affects how the microbubbles perform. Microbubble elasticity, or flexibility if you will, impacts how well a microbubble can respond or resonate due to the amount of pressure or power placed upon them, as well as how long a microbubble may resonate over a period of time before it cracks or dissipates. So a shell that is stiff can crack or break more easily, which impacts the imaging time. However, a shell that's more elastic or flexible, like Luminity, the greater its ability to be compressed and resonate to produce a nice and strong backscatter signal that we see with Luminity. The flexibility allows the Luminity microbubble to compress and respond quite well under varying power settings. The MI, or mechanical index, can be adjusted appropriately to meet the imaging needs of various patients that may require higher or lower power or MI setting. It's important to know that every patient is different and every MI threshold can be different. And that not only is the size of the patient, but also how far the sound wave has to travel, which we'll get into in a little bit. Consistency in size and distribution is another important factor contributing to microbubble performance. A small difference in the size from microbubble to microbubble can result in a significant impact on the echogenicity and homogeneity of the contrast effect. This is where mechanical activation with the vial mix is important. The vial mix delivers consistency in size and the number of Luminity microbubbles. This consistency produces uniformity in the way the microbubbles respond, which contributes to a nice homogeneous image that you typically see with Luminity. As we can see here, the microbubbles are resonating equally. Right? We have a nice homogeneous pattern of contrast from the base of the heart all the way down to the apex. All segments of the left ventricle are well delineated. Because the microbubbles are consistently sized, they're producing equal signals. The vial mix, as we mentioned, also delivers consistency in the preparation of Luminity. It minimizes operator error and allows the uniformity from vial to vial, which contributes to that predictable image quality we get from study to study. Luminity is the only ultrasound enhancing agent with mechanical activation. As the phospholipid composition of the shell allows for the microbubbles to respond well across a variety of power settings, it also offers high enhancement at a low dose. This is important as single vial is more than efficient to image in both rest and stress echoes. Okay, so now let's discuss optimization and administration techniques. Ultrasound systems have factory presets and recommended settings for contrast, which serve as a good starting point. And although these are typically a good starting point, some controls do require additional adjustments for each patient to achieve optimal results. Right? You wouldn't do an entire unenhanced echo without changing some of the settings. This is no different when using Luminity. The primary controls include the mechanical index, frequency, and focus. And these primary controls affect how the microbubbles respond to ultrasound, as well as provide the appropriate penetration to image varying patient types. Other controls, such as gain and dynamic range, are important. One thing to keep in mind is, just as in any echocardiogram, image optimization is important when performing a Luminity study, where the image always dictates the appropriate settings. Well, let's begin with mechanical index, or power, as this is an important control, one that can have the greatest impact on overall image quality. Mechanical index is a measure of the power output from the transducer, or the transmit power. With Luminity, it is important to keep the system power low enough so that the microbubbles do not burst. Yet we want the power high enough in order to penetrate the sound into the patient's body and to get the microbubbles to resonate. So choosing an ideal power setting for each patient is simple, as it is determined by what we see on the ultrasound monitor. In this example here, what's the appropriate power setting on this patient? Ask yourself, is the cardiac anatomy visualized well? Are the microbubbles resonating to produce a strong and homogeneous signal? And here, yes, right? We can see all of the cardiac anatomy well visualized. There's a nice homogeneous pattern of contrast with a strong signal response. So we're not hitting these bubbles at too high of a power because they're not bursting, which we would see with swirling, but the microbubbles are resonating consistently from the base all the way to the apex of the LV. Remember, MI, or mechanical index settings, vary from patient to patient and ultrasound system. Right? Everyone's MI threshold can be different. And it's not necessarily just about how large the patient is, it's about how far sometimes you have to travel when adjusting the power in the MI. Here we have an example of an apical 4-chamber view. And what I'm doing is I'm changing absolutely nothing else besides the mechanical index. You notice as the MI increases, the structures that are further away from the ultrasound transducer resonate brighter. If you look at the top right-hand side of the screen, you can see the MI increase. Now notice how in the very beginning we only saw the apex. Now we're actually increasing the MI more, and now we actually see a little bit of swirling. I'm going to let it play again. The furthest part of the heart from the ultrasound transducer here is the base. So it makes sense if we send a louder signal that it's actually going to resonate those bubbles that are further away from us, maybe 10 or 15 centimeters in this example. So it's not only about the size of the patient, right? It's really about how far the sound wave has to travel. And if you imagine a bubble that's 5 centimeters away and you hit it at an MI level of 0.3, it expands and contracts the bubbles nicely. Now, if you have to travel with that same power, another 10 centimeters, in this example, the base of the heart, it's barely going to resonate that bubble, right? And again, you know, in this example, from start to finish, it almost looks like there's attenuation in this image here. Then as we increase the MI, nothing else has changed in this image besides the MI. It's night and day. You only see the apex. As we increase the MI, now you see the whole heart. You see the whole volume. And then as I go a little bit higher on the MI, I actually start bursting the bubbles. If you think about a parasternal long axis view, right? So for example, the inferior lateral wall here is the furthest away from the transducer. So often a good tip sometimes is to increase the MI, which makes sense. You think of those bubbles that are 15 centimeters away. If I hit them with the same power or MI as a bubble that's a couple centimeters away, it's probably not going to resonate or oscillate those bubbles. And that, again, is what causes that signal, which allows us to see the volumes, allows us to see the left ventricle. So I want to take a moment to discuss very low MI. You may have heard about using very low mechanical index imaging. VLMI, or very low mechanical index, is a technique that uses multi-pole sequencing technology. Now, that's important because there have been many misconceptions that very low mechanical index is basically just lowering the MI less than 0.2. And that's not true. Right? VLMI is a specific technology that requires the installation of software to the ultrasound system via the ultrasound system manufacturer, if available, as not all ultrasound systems have this technology. The advantage of VLMI imaging compared with low MI harmonic imaging is that it offers better tissue cancellation and greater signal-to-noise ratio for an enhanced detection of microbubbles within the LV and the myocardium. It's important to know that very low MI imaging, again, is not just lowering the MI less than 0.2. Harmonic imaging should be used with appropriately adjusted MI settings to meet the imaging needs of each patient. Luminity does deliver consistent performance across a wide range of MI settings, including very low MI techniques. We can see here this is a system that does have a very low MI software. Again, we look at the MI here, it's 0.18, it's less than 0.2. But if you look at the breakdown of the different frequencies on the right-hand side of the screen, notice when on res, or a higher frequency, the send and receive signal below is the same. It's 2.2, 2.2. On Gen, it's also the same, 2.0, 2.0, and when we go down to penetration, it's the same. And this is, essentially, this isn't harmonics imaging. This is fundamental. Our signal that we're sending is the same as the signal we're receiving. It's not doubling. And that's important to know because an MI of 0.16 under a very low MI setting is very different than an MI of 0.16 if you're on harmonics imaging off of very low MI. One particular caveat for very low MI imaging is patients with non-compaction. So because of that greater tissue cancellation, sometimes you image someone with non-compaction, you want to see those trabeculations stay prominent, but with a very low MI imaging, you might actually cancel out the tissue. At a low MI harmonics imaging, we won't cancel out the tissue, and you can see those sinusoids or those pathways much clearer. So that's one, particular caveat where you would not want to image on very low MI imaging. Even if it looked better, the whole reason of doing an echo for someone for non-compaction, similar to the case we showed a little bit earlier, is you want to see if it truly is or isn't. On some of the systems, there is a very low MI software that you can have installed, and some of them you could simply turn off harmonics. In this example, we see the image on the left-hand side. Nothing else was changed besides turning off harmonics and increasing the overall gain. And you can see the volume a little clearer. Now this depends, number one, like I said, on your system, but also the rev level that you have on your system to see if it makes a difference. And I don't show this to say that you're going to do it on every single patient, but the idea of today is to know all of the tips, know all of the things that you can use in order to make the image look better. So there might be some patients that you turn off the harmonics on, in this example, and it helps, and there might be some that it doesn't. But it's up to you as the sonographer to make sure you try those, or to try those, to try to get the best image possible. Now let's move on to transducer frequency. The frequency affects the penetration of the ultrasound beam and the image resolution. Right? So a high transmit frequencies provide less depth of penetration, but we have higher image resolution. Low transmit frequencies provide a greater depth of ultrasound wave penetration. Greater depth of penetration, though, will result in lower image resolution. So when ultrasound waves need to travel further, such as in an obese patient or for the example in the parasternal lungs where we have to travel further to see the LV, lower frequency sound waves can be ideal. Here we show an example. Notice when on res here, the send and receive signals are double, right? We see 1.6 and 3.2. Now when I go to Gen, it's 1.3, 2.6. So I'm actually on harmonics. You notice the MI is also 0.27. Now I just click to penetration in this example, and you see the send and receive signal is the same at 1.6, but look at the MI. The MI dropped to 0.16. This is actually using that multipole sequence with that very low MI. So the reason why this is important is know what you're using, know what your systems are doing when you change the buttons, right? An MI of 0.16 on penetration, if you had 0.16 on an MI for an MI on res or gen, you may not see the heart. One other technique that we can use is the focus. Right, so we always want to keep the focus around the mitral annulus level, but there might be some specific patients, if you're looking to focus on the apex, you might want to bring that focus up to the apex in that particular patient. In this example, you can see as I slowly increase the focus to more opacify the apex and then actually just change the gains, it's like a light bulb is turned on. It's a completely different window, right? So let's watch that again. We see the focus. The apex is a little hazy. Maybe there's a hint of an aneurysm. And as we kind of move up a little further and then adjust the gains, you see this aneurysm, which we didn't see before. Why this is important, now focus may make a bigger difference on certain systems or certain patients, and some it may not. But I was doing this echo for the sole purpose of looking at the apex. I was suspicious of an aneurysm, so I knew I should try to change the focus. I might have to give a faster injection, which we'll get into later, but you see the difference in this particular patient the focus made. Again, another example, just showing one click of the focus here on the left. You can see there's a little haze in the apex and not much clarity as far as detail. Then the image on the right is just one click away and changing the gains, and you see a much clearer apex. You see much more detail. You actually see the base and the mid of the left ventricle pretty good as well. In some patients, in some pathologies, in some studies, that is the difference of finding pathology and not. What about overall gain? So here we see the image on the left-hand side, and you could still see the apical thrombus, but it's really hard to make out the volume, to really make out the left ventricle. The image in the middle is too high of a gain, which is very bright, but at least you can see the volume, and obviously all the way to the right we can see a nice opacification throughout the volume. So know that you can change your overall gains. Some of the systems you can change it after the fact, it's post-processing, but it can make a difference. Secondary to that, we can look at our dynamic range or compression. Right, so the dynamic range or compression are shades of gray. We look at the image on the left, very black and white. So we decreased our dynamic range or compression, and the image on the right-hand side, we increased it and very smooth. It's up to your eye to know what you like, but just know that that's another button that you can change, and in some patients it might actually make a big difference. Similarly to dynamic range and overall gain, we can change the grayscale or the map. Right? So this image from the left to the right, nothing else has changed besides the grayscale. These are post-processing techniques. And I kind of zoomed in on the grayscale itself. If you look at the image on the left, there's a little bit more shades of gray. The whites may not be as bright. There's more of a transition into black. But then we look at the image on the right and you look at the grayscale. You see there's bright whites throughout, and then it kind of goes right to black. And looking at the volumes, it actually makes it look like it brings the volume out a little clearer. So this image from the left-hand side, we can see there's a little bit more of a transition from the whites into a gray, into a black. The image on the right, we can see that there's much brighter whites and there's less of a transition into black. So sometimes this can be helpful. There's a post-processing control that is just making the whites brighter to bring out the volumes a little bit more. Again, this is going to be different to your eye. You might like it a little bit, a gray map with a little smoother rather than more whites, kind of more black and white. Again, you might not find this necessary to change, but in certain systems with certain transducers, this may make a big difference when looking at volumes. What about breathing? Right, so breathing, you can change all of the settings that we've talked about, and breathing is going to be the main one that brings in the image. This image, we can see when the patient exhales, at the end of the clip, the whole image goes away. The only way we were able to see the heart on this patient was by taking a breath in. Look at how far the apex is from the transducer. It's about 8 centimeters or so. You notice that my MI is actually a little bit higher. Right? It kind of goes back to what we said earlier. You might need a higher MI in order to see the heart if it's further away. And really the example is whatever you do at rest in the unenhanced image, you should do that when you use Luminity. Turn the patient on their side, have them take a deep breath in. Maybe it's a small breath in. All of the same techniques that you used before, you want to try to do again to ensure the best image quality and the best image window. To add on to that, the speed of injection, right? The administration rate plays a huge role. In this example, we see a fast injection, too fast of an injection caused an attenuation, right? So we can see how the apex is very bright, but we kind of shadow out the rest of the heart. And essentially there's such a high concentration of bubbles at the apex, it produces this cloud and prevents the ultrasound beam to enhance past this cloud. Right now, if we inject too slow in this patient, we see this kind of swirling. Right? And it's not as exaggerated in this example, but really it's a difference of seeing the apex in this patient clearly and well with too fast of an injection or too slow. Obviously with the optimized image, that's the kind of the nice spot in between. We can still see the apex, and we do still have opacification mainly from the base of the heart down to the apex. Looking at the too fast and the too slow injection, If you had to get rid of the fast injection or the slow injection, which one would you? And some people say they would get rid of the fast injection because that's an artifact. It caused attenuation. Well, you know what? In this patient, that fast injection is the one that showed me the apical aneurysm and also showed me that there isn't an apical thrombus. If you had that injection too slow in the middle, you can't clearly see that there's an apical aneurysm, and you definitely can't confidently say that there's an apical thrombus or not. An example here, we can see a patient who came in with an abnormal EKG to rule out an MI, and you can see the base of the heart is squeezing well, but the whole mid to distal portion of the LV is out. Kind of looks like a Takotsubo's patient, but this is definitely a patient that I would use Luminity on because I really want to see the apex. Going back to what I said, I also want to rule out an apical thrombus. Knowing that, I may have to give more Luminity. I may also have to give it faster, right? So here's a comparison. I can see the volume really well. Maybe this is a good image to get a Simpsons to trace a volume, but I can't see the very tip of the apex as well as I can when I gave a faster injection with more Luminity on the image on the right. I opacified the apex as well as I can and can confidently say that there is not an apical thrombus in this patient. It's another apical four-chamber view. This is a patient where just this apical four-chamber image alone told me that I needed to use Luminity, right? And you look at this, and it's not a bad, it's not bad patient, it's not a bad image, it's not bad image quality, but if you look at it, there might be a subtle hint of a hinge point, right? And I also look at this one, and I'm foreshortened. You can see that the RV apex is at the same level as the LV apex. That tells me I'm foreshortened, and I'm not really seeing the true apex. So I went ahead, gave Luminity, and we can see the apex is out. There is an apical wall motion abnormality. We mentioned about giving faster and giving more Luminity in order to fill the apex in these patients, but you also want to try something else, and that's doing a sweep. So in this patient, in that one frame, that one two-dimensional slice, I was able to bring out that portion of the apex that had a thrombus. This patient actually had an echo done 9 months prior. They didn't use Luminity. They didn't see the apical wall motion. They didn't see the thrombus. He came in with an abnormal EKG and also some stroke-like symptoms. So, very good possibility that this thrombus was bigger before, and we missed it. Here's an example, a long clip showing a fast injection. Now I want to cause attenuation. We see it attenuate in the right heart. That's always a good sign. It's going to attenuate in the left heart. We can see it opacify, and now I'm kind of sweeping to a two-chamber view. I'm going to go to a three-chamber view. We'll circle back. We'll look at the four-chamber view and then kind of do that sweep and look posteriorly to try to follow the apex. It's important to note this patient, the EF looks normal. And in some patients, you may give a faster bolus, and it takes 20 or 30 seconds before it even starts to fill into the right heart. These are patients that you might have to give more, or sometimes at the very end, I might follow it with a flush just to ensure to push all of that to the patient. Again, this is that other patient we used for the gain and dynamic range examples. You can see with a faster injection how we saw the apex clear. You want to see opacification all the way down to the apex. In this frame, it looks like the thrombus is just floating in the apex. There's an attachment somewhere, so I would want to sweep. You get a little glimpse of the attachment there, but it's very important to give sometimes a faster injection, maybe more definity, in order to see the apex when you can't. Here's an example of someone with a LV mural thrombus. You actually look at the unenhanced image, and it kind of looks like it could be a layered thrombus, or maybe it's just a false tendon there, but when we use Luminity, you can see that clear line from the apex cutting straight across, and you can see that there's no enhancement, right? This is a clot. This is blood that doesn't have vascularization, and the LV doesn't take a 45-degree angle turn when we go from the apex. In this patient, what's also important, we mentioned sweeps. is to not forget about the RV, right? If the RV function is down too, so we can see the LV mural thrombus in the LV apex. You can see as we sweep through, there's also that black echo density in the apex of the RV, which wasn't seen until this sweep was done. Again, here's another patient. The apex appears out, and there looks like a little line there cutting straight across, similar to the other patient that we saw. And, does this person have a mural thrombus? It makes sense. This was someone who had a big anterior MI. So we went ahead and used Luminity. I gave a faster injection to really opacify the apex. And that's probably just a false tendon, but it happened to be a false tendon in a patient with an akinetic apex, which really made us think that there could be a mural thrombus. What about the power of on-axis imaging, right? I mean, nothing is more important as a sonographer to knowing if you're on or off axis. And we can really ensure on-axis imaging and adequate visualization of the apex when we use Luminity. So you look at this as the same exact patient. You look at that off-axis image. We don't really see the apex. Maybe it looks like the function's okay. Then we go on axis, and it's a completely different patient. It looks like there's a big pseudoaneurysm, or in this case, the patient actually had apical hypertrophy, which developed into this big outpouch or aneurysm. Again, when I used Luminity, I wanted to make sure I was on that more lateral, that more on-axis window. Otherwise, I would completely miss the aneurysm. With apical hypertrophy, it's important to note, even if you know the patient has apical hypertrophy, we want to make sure that we see that very tip of the apex. These two examples kind of shows sometimes the progression. They can have a little outpouch or a little aneurysm, which can develop into these big aneurysms, almost looks like a pseudoaneurysm. And when they do have these aneurysms, number one, it's important to find it, because these patients are at a higher risk for sudden cardiac death, so they may put a device in. But also, it's important to see if there's a thrombus in there. So let's go over a couple of tips with stress echo. Being able to use the diluted bolus form with Luminity helps with stress echo to last a little bit longer. It makes it much easier to enhance the left ventricle. When you inject, you want to try to inject with about 30 to 60 seconds before the patient comes off the treadmill. You also want to be careful of too high of a dose, too fast of an injection, because the heart rate should be ideally faster. Blood is moving through quicker, so you want to try to compensate to not get attenuation by doing a slow injection and maybe not as much. So we reviewed the unique characteristics of Luminity and how it produces high image quality. We discussed the importance of looking at the indication before doing an echo. We also discussed the importance of knowing why you're using Luminity on a particular patient to know exactly what the question is you need to answer. We touched on some techniques of image optimization, also administration rate and dose. We know that each patient is different. We know that each pathology is different, and it's up to the sonographer to ensure that you're getting the best images you can, but most importantly, to make sure you're getting the right diagnosis. At the end of the day, it's really about getting the correct cardiac diagnosis, making sure we get the best images that we can to ensure high patient quality care. Thank you for your time.